Welcome everyone to today's program. I am Akanksha Jayanthi with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following the completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after the completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Mark Dixon leads the Mark Dixon Group, LLC, which provides integrated delivery networks and medical suppliers consultative assistance. He specializes in providing services for C-suite perspectives, accountable care organization implementation, physician clinical integration, and improving service delivery effectiveness. Some of his past experience includes serving as Regional President for Fairview Health Services and President and CEO of Community Health Network in Indianapolis, Indiana. Dr. Safara's primary administrative role is in operations for surgical services at the ProMedica Toledo Hospital. He has responsibility for the operating room environment and both inpatient and outpatient endoscopy centers. He is involved in strategic planning for surgical services for the ProMedica health system. In addition, Dr. Safara is a practicing board-certified general surgeon with special interests in gastrointestinal surgery, surgical oncology, and complex problems in general surgery. He has experience in minimally invasive and robotic surgery. It is now my pleasure to turn the floor over to Mark Dixon to begin today's presentation.
Thanks, Akanksha. That's great. Appreciate being here today and sharing with you some perspectives on the world that's changing around us. We're going to talk about 4 different things today. The first will be myself covering an IDN and hospital trend strategies from a C-suite perspective. Secondly, Dr. Safara will provide a little background on ProMedica Toledo Hospital and their experience with the SEDASYS system. And then Dr. Safara and I will also spend a few minutes just having a conversation and a dialogue around their decision, what was behind it. Again, as mentioned earlier, we'll spend some time at the end of this to give you a chance to get some questions and answers. If you could go to the 2 slides forward. Here's how I'll be covering with you today. Again, the first is talking about the major changes with health reform. We all know that, we're all feeling it, but I'll talk a little bit more specifically about how the C-suite is being impacted by it. And that'll lead us into a broader dialogue around what some of the bigger trends and observations that we have in healthcare delivery systems. I'll finish that section up with some winning strategies for IDNs. Next slide. So what are those major changes occurring with healthcare? Well, if you step back from it all and look at what are some of the macroeconomic drivers of healthcare, that's really what's behind a lot of our changes. Our country, we have a healthcare system that can't compete in a world economy. If we keep spending more in healthcare, we can't borrow our way out of where we've been. You've all heard of the 18% of GDP that's projected to grow to 20% of GDP by 2021. That's what's helping us to be less competitive on an international basis. But look at a couple of statistics on this slide. If the average cost of healthcare keeps rising, the average premiums for a family of 4 will be half of their household income by 2021. The average Medicare couple pays in $119,000 into the Medicare program, and they take out $357,000 in benefits. So I don't know, it doesn't work too well in my house when that happens. I'm guessing the same for you that are on the line with us today as well. So if you go to the next slide, you see that a lot of this really drove the healthcare reform that we're seeing in this country. It started with the Recovery Act in 2009, moved to the Affordable Care Act, or Obamacare as it's commonly called, and it really is transforming our overall healthcare industry. Many providers initially thought this might be a boom to providers as patients that don't have health insurance suddenly have health insurance and are able to decrease the burden of uncompensated care in our health systems. But the reality of this all is that the scheduled decreases in payment to providers in the United States over the period of time from 2013 to 2022 is $260 billion of reduced Medicare payments, or about 10%. So it's good that people will be covered, but overall we need to try to create more value for our country. So if you go to the next slide, I'll just quickly break down the components of the Healthcare Affordable Care Act. And there's really four components. The High Tech Act, so this is the portion of the act that really encouraged the adoption of electronic health records. Most health systems have been hard at work implementing Epic and Cerner and other enterprise EHRs. Part of the Affordable Care Act then covers for some reimbursement, if you will, some carrots, some incentives to be putting those technologies in place. Now those carrots are turning to sticks, and so if you haven't achieved a certain level of meaningful use by 2015, now Medicare will dock you some pay, if you will, and pay you less money for the work that you do. So that's the High Tech Act. It's good. We on the provider side really believe that's a good thing. Value-based purchasing is the second key component. And here's where instead of just paying for doing more stuff as health systems, they're going to begin reimbursing us, have begun reimbursing us to achieving higher levels of quality, achieving higher levels of patient experience, better efficiency, and frankly, better outcomes, better risk-adjusted mortality and morbidity. This is also really transforming health systems, and now we have greater than 6% of all of our reimbursement tied to these value-based purchasing for all cases. Now, what that can mean is the difference between making money or losing money for a health system. So paying attention to all of these value-based purchasing is the top of a C-suite member's minds. ACOs is a third key component, and that's really groups of providers coming together to deliver care and contract for care on a population basis, not just on an individual basis, but overseeing the care for 10,000, for example, 10,000 Medicare enrollees to help them improve their care, their costs, their quality, and their experiences. We'll talk a little more about that later in the talk. And lastly, insurance reform, coverage for all, lots of insurance regulation. So over this 9-year period as it's been implemented, as I mentioned earlier, lots of Medicare payment cuts. Medicare is typically about half of the business for a given health system. So for our biggest block of business, we're seeing actually decreases in payment, as I mentioned earlier, of around 10%. And keep in mind that 88% of the growth in the industry over the next decade will be Medicare patients, with the 10,000 people retiring per day. So our fastest growing product is having their expenses reduced, and it's going to continue to be reduced over the course of this decade. The good news, that's kind of the doom and gloom portion, if you will, but there is good news. The whole Affordable Care Act is really designed around the triple aim. On the next slide, you'll see a picture of that. This is really developed by Dr. Don Berwick, who is head of the Institute for Healthcare Improvement. Many of us see him as an icon in the field of really driving better care, better quality, and better experience for everybody. And the triple aim is really population health, experience of care, and per capita costs. The notion is that if you focus on all three of these, you will end up with lower costs. If we focus on just reducing costs, we might have an adverse impact on experience of care or on better health and better outcomes. And the Affordable Care Act is solidly centered inside of that triple aim. A quote from the president of the American Hospital Association is on the next slide, where actually the former president, he just changed last week, is that the fee-for-service reimbursement model as we know it today is dying quickly. We just don't know the date of the funeral. That's how many of us feel, and that 2015 is really very much a turning point, kind of a tipping point for the industry as we begin to move towards these new models. Which leads me to the next section on some key healthcare trends for the country. 5 key trends we'll talk about today on the next slide is consumerism, population health, physician employment, scale will win, and this relentless focus to reduce costs. So let's start with the first one, consumerism. We all know healthcare costs more. I'm guessing everybody on the call today has seen their copays and deductibles increase fairly dramatically over the last 5 years. Well, you're not alone. Patients are beginning to shop for their care. They're having higher and higher deductibles. Employers and payers are experimenting with the different models. And more folks are choosing retail health care, minute clinics and such, as a place to go. People know we're expensive, and their medical bills are actually one of the leading causes of bankruptcy in this country. So a couple of key studies and books that I saw in the last year. One is by RBC, and I love the title of this study. It basically says it was 2014, the birth of the healthcare consumer. Dr. Eric Topol from Scripps also wrote a book that was released earlier this year, which also I think says it all. And the title of the book was The Patient Will See You Now. So more and more we're having to become much more patient-centric as we move down the path of healthcare reform. Second key trend is population health, and this is this whole move from volume to value, from doing more stuff to doing the right stuff. So health systems are hard at work creating these accountable care organizations, putting in place these population health capabilities, and building out new models of care. These are fundamental care model changes and not just changing the way we finance care. They're care bundles, pathways, care management, care coordinators, introducing patient-centered medical homes into their primary care networks inside the large health systems, working hard to bake in evidence-based care into all that they do. So not just doing what we've been doing, but what's the literature say is the best thing and the right thing to do. And there is a business model for this ACO, or Accountable Care Organization, care transformation. It's really organizing a low-cost, clinically integrated network of physicians and other care providers, have a growth strategy targeting at more members, more covered lives, putting together sometimes narrower network performance-driven plans that have patients and physicians and other providers working together inside the network, and then working across the continuum into skilled nursing facilities and home health cares to really address how to keep as much of the business inside your own organization. The third trend is on the next slide. This is physician employment and integration. More and more physicians are becoming employed and getting aligned and engaged by health systems. In 2014, more than half the doctors in the country were employed by large health systems, and that's only increasing. Some of these models are tight, some of them are loose, but more and more they're getting not just involved in employment, but why do we do this? We really get them to align with the strategy, and more physicians like Dr. Severo, who you'll be hearing from here shortly, are placed in significant leadership positions within these organizations to help them achieve their plan, help them align the interests of the physicians and the other clinicians of their organization with that of the strategy of the organization. On the next slide, you'll see a little bit about mergers and consolidations. We continue to see more and more mergers and consolidations across the United States, and we see emergence of this national mega system ACO. $10 billion in revenue, 30-plus hospitals, 300-plus clinics. Right now, there's about a little over 400 major health systems in the United States. We see that continuing to consolidate over the balance of this decade, probably not down into the 50 or 60 level, but probably into the low 200s by the end of this decade. So more and more mergers and consolidations. I actually prepared this slide about last year sometime, and nearly every organization in this slide has been involved in some sort of merger and consolidation in the last year. The fifth trend then is this relentless focus to reduce costs. So why is that happening? You all are feeling that, I'm sure. Well, it kind of gets back to the fundamentals of our business. On the average, we lose about 6% on every Medicare patient we care for across the United States. So every single patient that comes through the door, we lose money on if they're Medicare. And that's about half of our business. I already mentioned earlier that Medicare is our fastest growing product, so we're going to lose more money, if you will, as large health systems. And the dirty little secret, and most of you know this, is that we make a fairly significant margin, sometimes 30 to 40 to 50% on our commercial business, on the people that are employed. And guess what? Commercial insurers and businesses, large businesses, Fortune 500s, are tired of subsidizing the Medicare market, the government. So we're getting a lot of price compression around the United States, which is really kind of driving us all to say we need to learn how to make money on Medicare pricing, how to improve our operating margin, reduce our costs such that if the whole country were paid at Medicare rates, would we be able to still have a healthy operating margin, that 2 to 4% operating margin. Key areas of focus in that space are cutting direct costs, FTEs. People are generally about half the expenses of any health system, but also focusing on drugs, services, and other sorts of things to negotiate pricing, reducing variation and utilization, increasing our efficiencies. Of course, hitting those value-based purchasing targets are very important to improve that operational performance, and then engaging physicians and creating value through population health management. So those are the 5 key trends, and I'll finish up just with a little bit about what our ACOs are looking like and some integrated delivery networks winning strategies. If you look at the next slide, you'll see the typical IDN response then as we begin to move into from volume to value. It really starts with changing the care. What's so different from what we're doing today from the 90s? In the 90s, we largely just changed the payment models down in the lower right hand of this slide. Every health system I'm working with in my consulting practice, they're very much focused on how do we actually change the care? How do we adopt, reduce variation between all the providers in our practice? How do we prevent patients from having something they shouldn't have? Perhaps we're overusing our imaging or overusing various types of surgery. To get to kind of, and having, so if a patient with heart failure shows up at any of the number of spots in our health system, they receive the right evidence-based care as part of that. So that's number 1, changing the care. And number 2 is changing the experience and really creating a better, more consumer-centric experience, so they're not just activated, but they're also engaged in their care and taking charge of their care. And of course, changing the payment models with the new ACO, shared savings, capitation, bundles, and a number of different kinds of economic models are out there that are being implemented and adopted by many, many different health systems. But it is a journey. If you look on the next slide, you'll see that we're kind of moving as an industry off the S-curve of volume-driven fragmented care. We find ourselves today in the yellow box beginning to jump onto the new curve of value-driven coordinated care. We've all heard many analogies as we move from this fee-for-service models to these capitation or global payment models that we have 1 foot on the dock. I'm from Minnesota, so I say we've got 1 foot on the dock, 1 foot on the wobbly canoe. We know we need to get in that canoe, but there's a high probability of getting wet if you jump too fast. So that's where we're at, and most of the economics of our time frame today is being driven by yesterday's curve, yet we know as an industry and we know as leaders that we need to get onto that second curve. On the next slide, you'll see the typical strategy slide that's shared with most boards by CEOs, that number 1, we need to create value through this changing the care, changing the payment models, changing the experience, and achieving that triple aim. We're typically then trying to recover more lives. It's a growth strategy. How do we work with more physicians, other health systems to really build out that clinically integrated model, and then, of course, improve more lives. On the last slide, we'll talk a little bit about the winning strategies for IDNs. There's going to be winners and there's going to be losers in all of this. The winners clearly are going to have a relentless focus in all areas of their IDN to reduce costs, become part of the solution for our country, and prevent us from having health care costs 50% of the average household take-home pay. And that includes that efficient care model, eliminating readmissions and unnecessary surgeries, improving throughput. Again, I mentioned earlier, people and processes will be a key focus, and of course, growth. This creation of value, that outcomes, experience, and total cost of care, those are their leaders on that. That'll position these IDNs to be successful under multiple different payment models. And they have to be able to accept and manage that risk. Integrated clinical and financial data across populations of patients and using the new so-called big data will be key. Proactive and reactive care coordination needs to be solidly in place. It's how we do it. And, of course, actively pursuing those population health ACO deals. All of that requires engagement by physicians and employees. So that's kind of a really quick overview of what's happening out there in the market and what are some of the trends that we're feeling from health reform inside the large health systems. With that, I'm going to turn this over to Dr. Severa just to share with us his experience at ProMedica Toledo Hospital.
Mark, thank you. Thank you for that nice presentation. And I thought I'd start with talking a little bit about ProMedica. There may be some ProMedica folks on the phone or people who are familiar with ProMedica, but for those of you who are not, we'll run through that, and then I'll tell the story of how we came to adopt SEDASYS at Toledo Hospital, And then as I'm doing that, we'll try to tie that in with the key trends that Mark elucidated there. So ProMedica is a not-for-profit, vertically integrated healthcare network. We offer a full spectrum of medical services to 27 counties in Northwest Ohio and Southeast Michigan. We've grown from about a $500 million company in 2005 to we expect about $3 billion this year, and we understand that we're going to need to keep going to try to get to that $9 billion right upper quadrant in Mark's diagram to benefit from scale. Right now we're 12 hospitals and 300 other facilities. We own and operate Paramount Insurance Corporation, which insures our own employees, and now as part of Medicaid expansion, we have a statewide Medicaid product in Ohio. Our mission is to improve the health and well-being of our communities with a focus on population health. We have experience in managing risk because of our insurance product. We strive to deliver excellent healthcare services at low cost while delivering excellent patient experiences and outcomes. And our core values are compassion, innovation, teamwork, and excellence. So the adoption of SEDASYS fit right in with our core value, primarily in the area of innovation. So specifically looking at the 5 key trends that Mark has categorized, how is ProMedica responding to those key healthcare trends? In consumerism, we're feeling it here in Toledo. Our local newspaper, the Toledo Blade, recently published an article similar to the one that was in the New York Times and Time Magazine talking about prices in the community. Our competitors are advertising prices on billboards and in newspaper advertisements, so we're acutely aware of consumerism and acutely aware of how important the patient experience is. Population health, the second trend, we talk a lot about, our CEO Randy Ostra talks a lot about the social determinants of health. So we have a focus on not only population management via the insurance product, but we have a hunger initiative. We've received some national attention for that. We're addressing food deserts by putting in a grocery store in the downtown community, and we're working hard to keep jobs in our community by committing to have our hospitals in the city, and we're remodeling an old steam plant down on the Maumee River where we're going to be moving our administrative staff, and that'll be happening over the next couple of years, because we fully believe that a strong economy helps population health. Like all of you folks, we're doing physician employment and integration. We have several co-management companies to try to work toward integration with our non-employed physicians. And our employed group, PPG, ProMedica Physician Group, is 600, 650 members and growing all the time. And scale, I mentioned that already. And then the fifth, the relentless focus to reduce costs. Of course, I think SEDASYS fits in really well with the issues of consumerism and relentless focus to reduce cost. And we'll talk about that. So how does that tie into SEDASYS? I thought I would just tell the story of how we came to adopt SEDASYS. SEDASYS, of course, is a device to allow a non-anesthesia provider to provide Propofol sedation. So Propofol has been around for a while. I mean, it's been widely available in the U.S. for about 20 years, primarily used in operating rooms. Highly regulated. When it was approved by the FDA, there was a requirement that it only be given by anesthesia providers, so CRNAs, anesthesiologists. It's characterized by its just very rapid onset, quick recovery, and lack of unpleasant side effects. There's some euphoria associated with it. And every time we talk about Propofol, someone will bring up the Michael Jackson story, and you will see as we go through this that if Michael Jackson had SEDASYS, he'd still be alive today. We'd be going to his concerts this weekend. But the beauty of the SEDASYS of Propofol is that the patients are awake and alert within moments of the conclusion of the procedure. They have no memory of the procedure at all, and within just a few moments, they're wide awake and feeling great with even a little bit of euphoria. So I do colonoscopy. I do EGDs as a surgeon, and prior to my full-time employment with ProMedica a few years ago, I was doing colonoscopy and EGD out in the community with Propofol. And I could see directly the benefits that we would have in those patients, where they were wide awake, feeling great at the end. But in those other hospitals and outpatient centers, the Propofol was being provided by anesthesia providers. So it always made me a little uncomfortable that the patients were getting this extra charge. You know, they didn't really sign up for that. And I think if you look at the trends across the U.S., about 70% now of endoscopic procedures are done with Propofol, and the incremental cost is, you know, somewhere between $500 to $1,000 added to the patient's bill to have the anesthesia provider there. So when I began to have oversight over our endoscopy centers, it was clear to me that ProMedica's endoscopy centers were the only ones in our community that didn't provide Propofol for the sedation. So I approached our anesthesia group and asked them if they thought they could be involved, and they're pretty strapped. I mean, we're asking them to do more and more things all the time. They are an employed group. We support that group significantly, and their response to me was, well, lukewarm. Maybe is a nice way that they responded to it. I mean, there was really a big negative on it. They thought that they were spread too thin. We'd have to hire more people, and we started looking at, well, that's going to add some increased cost to us to hire more to our anesthesia group that was already, you know, losing money. So I became aware of the SEDASYS system by reading a short news blurb where someone had interviewed Toby Cosgrove from the Cleveland Clinic and asked him, this was in 2013, you know, what are the trends to watch? What are the things to watch in 2014? And he had, you know, I think a 10 on that list. And number 3 was SEDASYS. He said this was going to be game-changing technology. I was unfamiliar with SEDASYS, like as many of you were at that time and maybe even are today. So I began to look into it and research what SEDASYS was. And it really sounded great to me. It struck a chord. So I contacted the folks at Ethicon and SEDASYS, and we began a discussion, and we implemented SEDASYS in January of this year. The early results have been great. We've done well over 500 cases this year. Our target is about 2,000 endoscopic procedures using SEDASYS. We do it on about, right now, 40% of the patients. It's approved for ASA 1s and 2s for upper endoscopies or EGDs and colonoscopies. So some patients that we don't offer it to. And I would say that the first quarter has been a wonderful success. It fits, to sum up then, I think rolling out SEDASYS fits very well with Berwick's triple aims. The patient experiences are fantastic. I mean, at the conclusion of the procedure, the patient will wake up and say, wow, that was wonderful. That's Propofol, but you can't give Propofol without an anesthesia doc present if you don't have SEDASYS. We think that it's going to decrease costs overall. If you look at the total number of endoscopic procedures in the U.S., the numbers are kind of hard to get, but there's probably around 18 million to 20 million colonoscopies done annually. Pick a low number, $500 incremental cost times that big number. It's a big drain on the resources of the healthcare system when it may not be necessary to have that anesthesia provider there. And in our area, population health, in Northwest Ohio, we've looked at the stats coming from the American Cancer Society. Colon cancer tends to present at a later stage in Northwest Ohio, which tells us that we're not screening our patients effectively enough. And we know that we have long backlogs of patients. So, in addition to the safety that we believe SEDASYS provides, we believe that there will be increased throughput that will allow us to do more cases with a more efficient cost structure. Let's see. So let me go back to the slides here. I've already described what the SEDASYS does somewhat, but let me go through this a little bit. So SEDASYS really is a monitoring device. It ties in the pulse oximeter, the carbon dioxide levels with capnography, the EKG, blood pressures, and patient's responsiveness. The patient has an earpiece in their ear, and they're told to respond to us. Well, the machine says squeeze, and they squeeze, and as long as the patient continues to respond, the propofol continues to flow. If there's an issue with any of these parameters, the propofol is cut off and the patient wakes up and becomes more alert. So this is the safety net that allows patients to have this and not get beyond moderate sedation. So we're looking for, we don't want these patients to be under general anesthesia or deep sedation. The truth be told, with conventional narcotic and benzodiazepine sedation for procedures, many times these patients do go into deep sedation, and they don't have the benefit of all the safety nets that are available with the SEDASYS. So our feeling is quite strongly that this is a safer way to do endoscopy. Let's move to the next slide. So we can go to the next slide again. That's some information on propofol. Some of the details you can get from the SEDASYS website. But part of the rollout of the SEDASYS system is intensive training for all the providers, the nurses and the physicians. And we offered it to all endoscopists, if you will, both surgeons, general surgeons, colon and rectal surgeons, and gastroenterologists. And I would say nearly all of them took us up on it. We might have had one or two stragglers, the general surgeons who don't do a lot of endoscopy, who weren't all that interested. But we rolled it out to everyone. And SEDASYS provides, or Ethicon provides, folks that come in and do the education for us. It starts with some online training, and then some classroom work, and then simulations in our, well, we did it here in our endoscopy center with active mannequins, so that we knew that if there were any issues, we'd be able to rescue the patients. I think it's important to mention, though, that the FDA approval for SEDASYS is contingent upon an anesthesia provider being available. And we're very fortunate because our endoscopy unit, the inpatient unit, is located immediately adjacent to the operating room. So we have anesthesiologists walking by the door all the time. And when we first rolled it out, they would actually come in to they were curious to see how the thing worked. And so we had many of them come in just so that they were familiar with the technology, so if we ever had to call them in a crisis. And in our first 500 cases, we've not had any crises, and we've not had to call them. We can move to the next slide. And for this information, you can get the detail from the SEDASYS website. Okay,
great.
Mark, that concludes my comments.
Yeah, thank you very much. It was a great overview of kind of where you've been, where you're at. It's kind of interesting. You're in a very unique role. You're doing big cases earlier today and caring for patients, doing procedures, and at the same time you're a leader running this division inside of ProMedica. So you've got, in my mind, a very unique perspective to kind of see both the business and the clinical at the same time inside your organization. What are some of the major observations, I guess, you've seen around how this has been adopted? Any surprises? Have people gotten engaged quickly? Has it been something that's been challenging to implement? Talk a little bit about your experience.
Well, I think early on there were some significant challenges, like any change, or disruptive change particularly, and I think SEDASYS is disruptive. it requires a lot of conversation. And we had to be sure that the state medical board and state nursing board were okay with it, and because there had been some regulations making it difficult to use propofol if you're not an anesthesia provider. In Ohio, anyway, that's been changed, but we had to kind of work through that to make sure it was okay. Nursing staff initially was very skeptical, a little reluctant. Our chief of staff is a colorectal surgeon. He wasn't really sure. So it took a lot of conversation and discussion. And in fact, I had to buy, 12 copies of Who Moved My Cheese and spread them around the endoscopy center to have everyone read those. This is going to be different, people. Once we kind of got it going and we got a little traction with it when the education started happening, and then when we rolled it out, and many of our gastroenterologists had not ever used propofol because they were in this island of no propofol. When they began to see what they could do, then it started taking off with enthusiasm, excitement. In fact, last month was our biggest inpatient month ever for colonoscopy, inpatient colonoscopy. So it's a little bit hard to explain that. I can't explain it fully, but it tells me that people are excited about this technology. Again, there was some inertia. We had to work with the anesthesiologists. I wanted them to sign off on it, and they were involved with many of the committees. One surprise that I had was, how many committees this thing had to go through to get it signed off. And I found myself many times, on a 12-member committee that I knew that we were going to have a majority vote. That I'd call everybody on the committee to make sure that they fully understood. One misconception that people have is that it's going to eliminate a nurse in the room, and SEDASYS doesn't do that. You still have two nurses in the room: a procedural nurse and a sedation nurse. And now that sedation nurse is looking at the parameters on the SEDASYS machine, while she's looking also, he or she looking also at the patient. So that's one thing that needs to be made very clear. This doesn't eliminate staff in the room.
Real good, real good. And I'll remind the audience, we're going to be taking questions here in a second here, so if any of you have questions, please write them in as well. I'll ask one more question, and then we'll move it over. I like what you said earlier about you're listening to Dr. Cosgrove from the Cleveland Clinic, and this would be one of those real breakthrough technologies. And I want to kind of link that to the notion that you talked about earlier about not getting beyond moderate sedation. There may be many in the audience that aren't real clinically oriented, and if you could maybe talk about what is the impact of not getting beyond moderate sedation from a business standpoint. Why is this a breakthrough? Why did Dr. Cosgrove see this as a breakthrough? How can this really improve both the business side and the clinical side of our health systems?
Well, let me describe the levels of sedation. So the lowest level is going to be anxiolytic, where it's just to kind of make the patient a little more comfortable. So we want to get a little bit beyond that, where the patient is very relaxed, very comfortable, might be snoozing a little bit, but is easily arousable. If we say, hey, take a deep breath, they take a deep breath. We start getting down into deep sedation. The problem is that the trajectory to general anesthesia can go very quickly. So the SEDASYS puts us on notice, if you will, when the patient's starting to get into deep sedation. If you don't have SEDASYS kind of there telling you that, it's very easy for the docs to give more sedation than might be necessary. So what you see then is docs will give maybe sedation. They should never be giving it with an intent to have deep sedation. But the truth is, if I catch them in the locker room and I'll say, what is your intent when you're sedating people? Someone will tell me, I don't want the patient to move. But if you do that with conventional longer acting narcotics or benzodiazepines, it takes a while for the patient to recover in the recovery room.
Right.
So from the cost side of things, from the throughput side of things, you can use propofol, moderate sedation only, get them there very quickly, do the procedure more quickly because the patient's very comfortable, And when you turn off the Propofol, the patient's awake in about 5 minutes. So the throughput's more effective. When they get to the recovery room, we're finding, somewhere 30–40% quicker that we can get them out. I mean, we're still kind of collecting all of our numbers, but it's looking like we could probably get to a point where we can get a patient in and out totally, procedure, recovery, the whole thing, 1 hour. So if you start to do that, and if you typically do 12 procedures a day per suite, you can probably bump that up to 13, 14 pretty easily. So with no increased staffing, no overtime, because when the patients are done with the procedure, they go home. So you can work a little bit longer into the day. So I think that's where the safety and the cost effectiveness comes in.
Yeah, exactly, and it decreases kind of, in my words, the total cost per case, because you're getting much more efficient both in the procedure room and in the recovery space with the care that you're providing. Do you have any other advice for healthcare administrators out there that might be considering this or looking at opportunities to improve quality, reduce costs, improve safety?
Well, I think the SEDASYS warrants a serious look. I think it's going to be a little easier for most folks to introduce it if they are in a situation where we were not yet providing Propofol. So that's 30% of places in the country. I think there could be some significant challenges if the anesthesia providers are already there, but depending on how strapped they are. I mean, if you really talk to the anesthesiologist, they'll say, you know what, we don't really need to be there for an endoscopic procedure. Our skills are better served, putting a patient to sleep who's having a liver resection. We don't need to be there for those smaller procedures.
Very good, very good. Well, at this point, maybe I'll turn it back to the moderator. Looks like some questions are starting to come in.
Yeah, thank you, Mr. Dixon and Dr. Sfera, for a very informative and enjoyable presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A, and will follow up on questions they do not have the opportunity to address. All right, so our first question, who is the decision maker in terms of greenlighting the idea, then the pilot and the test, and the budget? Which is the key factor? Does the return on investment argument or patient experience trump?
In my view, the patient experience trumps. Patient experience, patient safety. But I think that when you look at the ROI, the numbers look pretty good, contingent upon you being able to see the increased throughput. In my situation, being both a clinician and a decision maker, it was a little bit easier. I think probably in most places, though, it's going to probably be the clinicians who are going to drive it like it is many times. And I think you'll see once they start getting excited about it, you'll have to work the numbers. But I think if you look at it carefully, it is a cost saver.
Yeah, I would concur. I do not think it's going to be introduced as a cost-saving opportunity for the health system that might have some impact on safety and quality. I think it's going to clearly come in through the safety and quality and reduction and adverse effects and so forth door. That's how it's going to be integrated into the organization. And when someone asks what's going to trump what, in my mind, it's not even a Trump situation. There, as I mentioned earlier, there's all sorts of complex issues that are hitting our C-suites and our leaders in these health systems simultaneously. And so very, very often you're having to kind of look at complex situations that have quality, that have safety, that might have increased expense, might have the potential for decreased expense. And so it's really trying to put together a broad plan that addresses all of these issues and has something that speaks equally to the clinical audiences inside your organization, as does it speak to the financial audiences inside your organization. So to me, it's kind of both. But that's, to me, the beauty also of SEDASYS, that it achieves meaningful results in both the clinical quality safety arena as well as in the throughput financial ROI side of the house.
On the patient experience side, I might add, of course, we get paid for patient experience scores, and
Good point.
my endoscopist will tell me that frequently they do poorly on communication scores because the patients are given a medication to make them forget, midazolam primarily or Valium-like drugs, and then 2 days later or a week later they're asked, did the doctor talk to you? How was the communication? Well, they don't remember that the doctor talked to them at all, and sometimes the doctors really wouldn't even talk to them a whole lot because they know they would forget. Now they wake up, and within 5 minutes the doc's explaining to them what they found, bad news or good news, and it's their head is clear at that point. So we think it's going to turn into better communication scores. Haven't been able to quite see that yet, but we think that's going to happen.
It really ties nicely to that whole trend of consumerism as well, and as patients begin shopping for more of these services, as patients begin paying out of their own pocket for these services, having that better experience, really understanding what happened to them is a solid link to that broader trend of consumerism.
Wonderful.
Agreed.
Thank you. Oh, great. All right, so next question. You had mentioned in the presentation you had to get anesthesia approval. Did they feel threatened or under the impression that some of their business was being eliminated?
Well, did we really have to get their approval? I mean, probably not. I really wanted to get their buy-in probably more than anything, and I needed them, those who had a vote on some of the committees, the quality committees, I needed to have them say yes. I needed their votes. Did they feel threatened? Yeah, probably some. In fact, there was a Washington Post article regarding SEDASYS earlier this week. I don't know if any of the audience saw that, but it was entitled something like "A New Machine May Eliminate the Need for Anesthesiologists." Well, I was interviewed for that, but that wasn't exactly what I said. But I came into work the next day, and an anesthesiologist said to me, "Hey, your patient in slot 1, we're having a hard time getting the IV in. Maybe you can call the SEDASYS machine to come over and put it in." Well, thanks, Mike. We're having some fun with it, to tell you the truth. I mean, my guys are really busy, and as I said, I talked to them first, and there really wasn't a lot of enthusiasm to get there. But I think there will be some challenges for folks where anesthesia groups are depending somewhat on revenues they see. But if you're responsible for the total cost of care, I mean, I think it's in everyone's best interest to try to do it most efficiently in the most cost-effective way.
Yeah, I would just add that there's a number of hospital-based specialties out there like anesthesia, pathology, radiology that have been heavily linked into the fee-for-service model. The more the stuff they do, the better they've been compensated as individuals, as a profession. And more, many of their professional societies are stepping back and trying to sort out how do we play in this new value-based world? What's our role? What sorts of different things do we need to lead? How do we lead differently versus how we've led in the past? And so that's part of the process, I would think, is if they're feeling threatened, they may be feeling threatened around the model that we've been in, and really haven't fully conceptualized what's the model they need to begin moving into as a profession and as a group of doctors. And I'm guessing that was also part of the dialogue that you had with them, Dr. Severa, of helping them sort out how can this be good for you and good for your patients. And in fact, earlier you even mentioned once many folks saw how this was actually so much better for their patients, that was the biggest encouragement you could ever see of getting on board and not feeling threatened with it.
Yep.
All right, wonderful. Thank you. Our next question, is there any concern to where patients could become alert during this process?
Well, I think in any endoscopic procedure there are times when the patients become more aware. So that doesn't really change. I think though we are more able to effectively get them to that satisfactory level of moderate sedation when we're using propofol. But in any procedure, the patients can become a little more alert. SEDASYS, though, has the ability for us to give them additional doses of propofol. So the SEDASYS machine at the beginning of the procedure, you dial in a weight-based flow rate, and if the patient seems like they're a little bit more alert, and we can actually follow the response times. The way this thing works, as I mentioned, they have an earpiece in, the computer tells them squeeze, and then we look at how long it takes for them to squeeze. And so we really don't start the procedure until there's a delay of about 7 or 8 seconds until they respond. So then you know the patient's there. If that delay from the cue to squeeze to when they actually do squeeze starts to get shorter, it implies the patient's getting a little lighter, and we can give them a bolus of additional propofol to help get them back down to that level where they're comfortable.
All right, great, thank you. We have another kind of clinical question related to patient experience. Can patients leave or even drive home more quickly or at all if this technique is used?
Well, we absolutely believe that they can leave more quickly, and we're showing that, and we have the numbers. We have the data. I think, the first hospital to roll this out was Virginia Mason out in Seattle, and they've got pretty good data now that shows dramatically about 20 minutes, 15 to 20 minutes earlier, the patients can get out of the unit. We are not ready to say that they can drive, but what I tell people all the time is I think that people, when they leave out of here now after propofol sedation with SEDASYS, they're ready to go to breakfast. Whereas in the past, I think with the longer acting drugs, they would kind of go home and many times, just kind of sleep the day away. So I think you kind of get a day back, by doing this. But for sure, the throughput's better. They go home quicker. We're not ready to let them drive home yet, though.
Okay, wonderful. Thanks. All right, next question. Propofol is generally associated with deep sedation. This is minimal to moderate sedation. Were you originally concerned that your patients would not be satisfied?
Yeah, I mean, we still have that concern. I mean, propofol can do deep sedation or can really do general anesthesia. And part of the training that all of the staff went through was to really understand more deeply the different levels of sedation and to understand how patients with certain drugs like propofol can jump from one level, they can skip a level. So, we had more concerns about patients being too deep rather than being too light. Having seen patients sedated with propofol, though, even in the absence of SEDASYS, to me it was just pretty clear. It's anecdotal, but it was pretty clear the patients do better. They just feel better. In fact, before I got on the phone here today, I walked through our endoscopy unit and saw a nurse sitting there, and I said, she just does some per diem work, so she hadn't been in the unit much lately. And I said, well, you're seeing the propofol patients today. How's it going? She said, it's great. It's fantastic. They're ready to go in no time at all. So yeah, there's issues, that you have to work through, but the education and training is a big part of it. And I think in the end, the patients do have a much better experience.
All right, wonderful, thank you. Our next question, can you comment on the value that this offers to patients? Hospitals are trying to develop strategies that will attract patients with the promise of value and quality outcomes. Can you comment on this a little bit?
Mark, you want to take that one?
Yeah, I think we've talked about many of these things through the course of today's session, but the value proposition from a patient standpoint, of course, who wants to be in the hospital for an extra half hour or an hour? Who I think they'd rather get home earlier and go home less groggy and so on and so forth. I think the other big aspect I think that was touched on earlier is one of the real challenges that we begin to move from volume to value, and so some of these new models of population health is really achieving higher levels of performance with our preventive measures, with our colonoscopy rates for patients over the particular age group based upon their risk and conditions and such. So if it's a less intensive procedure and seen as more pleasant and better accommodated, hopefully patients as a population will more often get screened. So, I mean, the sense we've gotten certainly, and again, I'm not the clinician here, but just anecdotally from the folks that have been through this, are very aligned with what Dr. Safara has talked about, that the patients like it better, the staff that are working with it like it better. It has a favorable impact on throughput and costs and staffing. As I mentioned earlier, staffing is probably one of our number one areas as we are trying to get to a lower cost per case and a lower total cost of care as a society. Staffing is often where we go towards. So on one hand, we have the 10,000 people a day retiring in this country and moving into Medicare and driving more demand. And so how can we care for them more efficiently and effectively without having to build out more facilities? But I think the experience piece is very key. So it's, from my sense, talking with Dr. Safara and others, it's not been a hard sell. It's actually been something that pulls patients into it as opposed to trying to push patients into it.
Wonderful, thank you. Our next question, how did you convince your colleagues in the C-suite, and how did you work through that decision-making process?
Well, as I pointed out, we were the only group in town that was not providing propofol sedation. So in one sense, that was one of the major drivers, that we really had to get on board and figure out a way to provide propofol sedation. 70% of colonoscopies in the country are using it now. Our docs were the only ones who weren't. Patients were starting to say, you know, I want my colonoscopy with propofol. So in one sense, it was kind of a defensive strategy. But you know, the second was we have a major patient safety initiative going here, and we believe that this is a safer way to provide sedation overall. While it's not FDA approved for anything other than ASA 1 and 2 colonoscopies and EGDs, you know, I dream about the extension of the technology into other areas. So I think this is just the beginning of things. So defensive strategy, increased throughput, better patient safety, better patient experience. I think all of those were enough to kind of win the day.
Great, thank you. And I think we have time for one last question here. Can you talk a little bit more about what your nurses thought about bringing in this new system?
Yeah, well, as I mentioned, that early on the nurses were a little concerned, a little anxious. The ones who'd been around for a while, we've heard some stuff like, oh, geez, we've been doing it this way for 20 years, why would we want to change? So you know, there was some buzz about that, but it took me getting into this suite and talking to people and trying to get them excited about it and talking about, you know, being enthusiastic about change. Again, now where we are is general enthusiasm. We've got some of the nurses who've just embraced this thing and have become our local experts and you know, do it better than some of the other nurses and poke their head in and make sure that everyone's doing it up to what they believe is their standards. I mean, they've really become very passionate about it. So right now I'd say it's a real winner with the nurses. They love it.
Wonderful. Well, I want to thank again our presenters for their excellent presentation and for all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.